Assalamu alaikum. Today, inshallah, we will continue our explanation in Kansky book strabismus chapter. And today, the second lecture, we will start with the ocular movement. Yes, Dr. Sani, can you read, please?
Reductions are monocular movements around the axis of Hicks. They consist of adduction, abduction, elevation, depression, intorsion, and extorsion. They are tested by occluding the fellow eye and asking the patient to follow a target in each direction of gaze.
Just to make it
Vergence.
easy here, what is the difference between duction and aversion? Just in one word, the duction is monoocular, the version is binocular. Okay, so when deduction, that means one eye or just movement of one eye, abduction, adduction, elevation, depression, intorsion, extorsion, just in one eye. Version when both eyes, so it's conjugate movement in the same direction. So the version, they are binocular, simultaneous, conjugate movement in the same direction. This is the meaning of the version. So deduction is just monoocular movement, and the version binocular, the both eye, and it's conjugate, because now later on we will talk about this conjugate. Okay, yes, read the version.
Dextroversion and levoversion, gaze right and gaze left, elevation, up gaze, and depression, down gaze. These four movements bring the globe into the secondary position of the gaze by rotation around either the vertical Z or the horizontal X axis of Fick. Dextra elevation and dextra depression, gaze up and right, gaze down and right, and levo elevation and levo depression, gaze up and left, gaze down and left. These four oblique movements bring the eyes into the tertiary positions of gaze by rotation around oblique axis, like in the listening plane, equivalent to simultaneous movement about both the horizontal and vertical axis.
Okay, so here
There's
versions, we have the dextroversion and levoversion. Dextro, the word of dextro mean right, and levo mean left. Okay, this is two words, you should remember it. So when we said dextroversion, we talk about right, levoversion, we talk about left movement. So dextroversion, gaze to the right, levoversion, gaze to the left. When we said then dextro elevation, dextro depression, so here right and elevation to the right side. Dextro depression, depression to the right side. The same thing, levo elevation, elevation to the left side, levo depression, depression to the left side. This is in normal way. So how here the dextroversion, levoversion, and the up gaze, down gaze. So here these four movements bring the globe into secondary position. So here we don't talk about primary position, we talk about secondary position, because the eye, it go to the right or go to the left, or it's elevate and depress to the right or left. So this is the secondary position of the gaze by rotation about, we talked about yesterday, the vertical Z and the horizontal axis of the figure. These are the imaginary axis. You can imagine how the eye or the globe it moves. The same thing for dextro elevation and dextro depression. The four oblique movement bring the eye into the tertiary position. So here we talk about tertiary position when we talk elevate to the right and elevate to the left, or depress to the right or depress to the left. We talk about a tertiary position here. Okay, but when we talk just dextroversion and levoversion, up case, down case, here like to the right, to the left, up, down, this is secondary position. But when we said up and right, up and left, down and right, down and left, we talk about tertiary position of the gaze. This is because we depend on the oblique axis, and we depend on the oblique muscles here also, equivalent to simultaneous movement about both the horizontal and vertical axis. We will work at two axes. Then the last thing about the torsional movement, to maintain upright images occur on tilting of the head. So here when there is head tilt to the right and head tilt to the left, here we have torsional movement. These are known as the writing reflexes. Okay, So these are, they call it the right hand reflexes. On head tilt to the right, the superior limbi of the two eye rotate to the left, causing intorsion. So when you make head tiltion to the right, there is intorsion to the right eye, okay, causing intorsion of the right globe and extorsion of the left globe. This is very, very important, and this is how when we make three-step test. Just I will explain this, then you will read the Vergences. So just always to all of my students, I told them the three-step test when you want to Bolshevsky test. What is three-step test? When you do it, first of all, you look at the both eye in the primary position. We will talk about this in the neuro ophthalmology part. Then you tell the patient to look to the right and to look to the left. Okay, this is the second step. Okay, and the third step, you catch the head of the patient and you tilt it to the right side, then to the left side. This is the step number 3. And when you tilt your head to the right side, just make head tilt now during I'm talking with you. So what's happened to your right eye? The right eye, okay, it will be intort, and your left eye, it will be extort. And if you make the head tilt to the left side, your left eye, it will be intort, and your right eye, it will be extort. So this is the rule. This is the normal. And when we have fourth nerve palsy, okay, we have fourth nerve palsy, we have a rule to make it to make it simple in the fourth nerve palsy. We said woog, okay, and boot. What is boot and woog? Boot better on opposite tilt. So you have right fourth nerve pulse in the right eye. So when you make head tilt to the left side, the palsy, it will not appear. Okay, this is boot. And walk worse on opposite gaze. So he is have right corner palsy. When he look to the left side, he has worse of the condition. And he has better on opposite head tilt, but worse on opposite gaze. Woog and boot. This is how to remember the rule of the fourth nerve palsy. We will talk about it in detail more in the chapter of the fourth nerve palsy. So the head tilt, always when you make head tilt to the right, your right eye intort, your left eye extort, and the opposite is true when you make the left head tilt. So here, let us just look at the picture. This is the Vergence. Again, the Vergence, it's binocular. So both eye, they are conjugate, simultaneous, binocular, simultaneous, conjugate in the same direction. Okay, so here, when we have looking to dextroversion, the same, look at the same arrow, the left eye, it will also go to the dextroversion, look to the right. And when he has depression, both eye will be depressed. And when we have version, look at the arrow in the same shape and the same color, they will go there. And here we have the convergence and the divergence. We will talk about the convergence and divergence. I hope it's clear until now. Yes, Saina, read the divergences.
Vergences are binocular simultaneous disjugate movements disjugate in opposite directions so that the angle between the eyes change, also termed disjunctive. Convergence is simultaneous adduction, inward turning, and divergence is outward movement from a convergent position. Convergence may be voluntary or reflex. Reflex convergence has 4 components. Tonic convergence, which implies inherent innervational tone to the medial recti. Proximal convergence is induced by physiological awareness of a near object. Fusional convergence is an optomotor reflex that maintains BCV by ensuring that similar images are projected onto corresponding retinal areas of each eye. It is initiated by bitemporal retinal image disparity.
Okay, before the
Accommodative
accommodation, let us just make the things more clear. So in the versions, here it's CES, okay? And here the versions, just look at its version IONS, okay? So here we call it in the same direction or conjugate. When it's GENS, the end of the word, the versions, this is disjugate, not conjugate, okay? So here they are in the same direction. But when we said versions, this is in the opposite direction. This is the differences. This is very important just to differentiate what is versions with GENS, what is versions with IONS, because many people they confused when they said versions or versions. Okay, here disjugate, but in this one conjugate. This is the first thing you should be careful. It's the same, binocular and simultaneous, but they are disjugate, not conjugate, and not in the same direction. They are in the opposite direction. So the angle between the eyes are changes. In the versions, the angle between the eyes are the same. Just here they write it, just to make the thing more clean. The angle between the eyes remain constant, okay? But the angle in the versions between the eye, it's not constant. As we said, it's different, okay?
Mhm.
Yes. So here, this jacket and the angle between the eye are changes, not constant. So we have two type of divergence movement. We have the convergence when the both eye go inward, and we have the divergence when the both eye go outward, just in a simple way. Okay. So inward turning, convergence, divergence, outward movement. Okay, form from a convergent position. Convergence may be voluntary or reflex. So we have voluntary convergence and we have as a reflex convergence. Voluntary, just tell him to look at a near object. This is voluntary. Reflex, when something come beside the eye, there is a book, there is something you look for a near object, then the near triad occurs, so there is convergence. Reflex convergence had four components, and these are important. So the convergence, how it's happened, there is tonic, okay, there is a proximal, and there is a fusional, and there is accommodative conversions. The most important thing, all of them are important, but the most important thing you should understand is the accommodation, because all of the strabismus, especially the esotropia, also the exotropia, it depends on the accommodation and how we can measure it. Okay, so the tonic convergence, which implies inherent innervational tone to the medial recti. So there is a tonic or there is innervational to the two medial rectus muscles. Okay, this is, we call it tonic conversion. This is the innervational that go to the medial rectus muscle. This it make a tone in the muscle that lead to the eye to converge, to go to inward movement. The second one, the proximal conversion, is induced by psychological awareness of a near object. So proximal mean near. Proximal mean near. So there is near object. So psychologically, your brain directly let the eye to make convergence to see the near object for anything. This is, we call it proximal convergence. So the tonic by inherent innervational for the two medial recti. Proximal is psychological awareness because there is a near object. A fusional conversion is an optomotor reflex that maintain binocular single vision by ensuring that a similar image are projected into corresponding retinal area of each eye. This is very important. Now I will explain it. It's initiated by bitemporal retinal image disparity. So always we have the eye it take one picture and the other eye it take one picture. And if we didn't have a fusional in our brain for these two pictures to make it like one picture or reading it as one picture, it will happen a suppression. So the fusional, it will, like you have a near object, so both eye, it will be convergence to make the two image like fall in the same points in the planes to make the fusion of these 2 points. This is the fusion, like just in a simple word. So the fusion, it's very important, and any disturb in this fusion, it will end with amblyopia or squinting or misalignment. So it's optomotor reflex. Okay, so there is motor reflex, there is reflex, motor reflex movement. Maintain the binocular single visions projected into the corresponding retinal area. Corresponding retinal area, this is the retina. Okay, so at this area, it take the image in the corresponding in the other eye at the same area it will take. So these 2 points, it will be corresponding to each other in the both retina. This is the meaning exactly corresponding retinal area of each eye. So there is bitemporal retinal image disparity. We will talk about it in the sensory part in more detail. Okay, so there is bitemporal retinal image disparity. One image come at the temporal side here in this side, and the other one at temporal each eye. That will make the convergence of the eye to make the fusional part. Okay, in in this way. Okay, I think we will see some picture later on in the chapter about this, what we talk about it, the fusion. We will talk about it in detail. Then the accommodation. Yes, can you read the accommodation, please?
Accommodative convergence is induced by the act of accommodation as part of the syncretic nerve reflex. Each dioptry of accommodation is accompanied by a constant increment in accommodative convergence, giving the accommodative convergence to accommodation. ACA ratio. This is the amount of convergence in prism dioptries per dioptry change in accommodation. The normal value is 3 to 5. This means that one dioptry of accommodation is sated with 3 to 5 of accommodative convergence. Abnormality of the ACA ratio play an important role in the etiology of strabismus.
Okay, I will give an example now. So for accommodative conversions, this is very important topics. Is induced by the act of accommodation as part of synkitic nerve reflex. What is the synkinetic nerve reflex? Nerve reflex or nerve triad, it's a three thing. We have the accommodation, we have the conversions, and accommodation and conversions, and we have the near object that will make the near triad. Sorry, meiosis. Number three is the meiosis. This is the near triad. So we have accommodation, conversions, and meiosis. This is what we call it the near reflex or the near triad. So it's a three component. Okay. What is the accommodation and how it's occur? Before I explain this part in Kanski, let us understand the accommodation, because the accommodation, if you understand it, everything become more easy. So the accommodation, there is more than one part of the accommodation. I will start in this picture here. Okay, so what's happened in the accommodation? The first, number one, there is ciliary muscle, okay, contraction. Okay, here in this picture, here the accommodation. So ciliary muscle, it's start to contraction. The contraction of these ciliary muscle, it will make laxity in the zonule. Look at the zonule become more lax. When it's contract, the zonule, it become not stretching, it become laxing, relaxed zonule. So contraction of the ciliary body muscle, relaxation of the zonule, and the shape of the lens, it's change. Look at it, it's become like more big, become more forward. Look, so globular shape of the lens. So contraction of the ciliary muscle, relaxation of the zonule, change in the shape of the lens, that will change in the refraction of the eyes. Okay, so the ciliary muscle contract, slacks of the zonule, the lens round to greater strength for close vision. And when the lens, just imagine it become like this, more globular in shape, here it's flat. Okay, here there is relaxation of the ciliary muscle. The zonule are strengthening, or it's a strengthening zonule, and the lens it's flat. This globular lens, it will make myopic shift. Okay, it will lead to myopic shift. So accommodation mean myopic shift. Is it clear? This is the meaning of accommodation,
Mhm.
myopic shift, because the lens it change. If you just imagine the refraction of the eye, how it enter when the lens become more globular, like more convex, it will pull the refraction light from behind of the retina toward in front of the retina. So this is myopia, from behind to in front of the retina. Okay, so there is myopic shift. So this is the accommodation. The eye accommodate by close vision by tightening the ciliary muscle, allowing the crystalline lens to become more rounded and more toward myopic shift. So here, for a close vision, always when there is any near object, the eye it will accommodation. And always this accommodation, it's associated with convergence. The eye become more convergence. Okay, and this accommodation with convergence, when you look at a near object, the meiosis also it's occur to make it more clear. So this is what we call it the near triad. Okay, sorry for interruption. So here the accommodation here, you can see when the lens there is relaxation, there is no accommodation, the lens become more flat, so it's become the light, the lens it refract the light for the distant vision. Okay, look at the light here, it make it behind the retina, or it make it hypermetropic shift, not myopic shift. So here you can see the distant vision. So the light rays from the distant object are nearly parallel and don't need as much refraction to bring them to the focus. For the close vision, here the light is very near, so we need convex shape of the lens to make it more focused toward the retina. Okay, so here the light rays from a close object diverge, okay, and requires more refraction for focusing. This is why we make accommodation, we make the myopic shift to make the refraction light go toward the retina. Here you can see the picture of the relaxed lens, how become more globular shape, and all of the light it will, when enter, become like this. And here closed focused eye become more globular, more than this one. Right. And the last picture here, accommodated for near object to care from relaxation of the zenule. During far vision, the ciliary bit relax, the zenule stretch, and the lens flattens. And there is here, I think, video for this. I will share it, inshallah. So let us come back to Kansky book. So here we said each diopter of accommodation is accompanied by a constant increment in accommodation convergence. So each one diopter of accommodation, there is increase in the accommodation convergence, giving the accommodation convergence to accommodation ratio. So that each one diopter of accommodation, how much it will give you. Here they said, this is the amount of conversion in a prism diopter where diopter change in the accommodation. So the normal value is 3 to 5 prism diopter. This means that one diopter of accommodation is associated with 3 to 5 of accommodative conversion. So each one diopter of accommodation, it will equal to 3 to 5 of accommodation convergence equality. This is the equation of accommodation. So each diopter, it will equal from 3 to 5 of the accommodation, 3 to 5 of accommodation conversions. Abnormalities of this AC ratio play an important role in etiology of strabismus, and we will talk about it. Change in this accommodation, conversions, and the pupil size, which occur in concert with a change in the distance of viewing, are known as the nearest triad. Before we go for the position of gaze, let us understand how we can calculate the ACE ratio. There is two methods for calculate of the EC ratio, the heterophoria method and the gradient method. There is a beautiful question in the Massachusetts. Always I love to read it with each student to let him understand how we can calculate it. Okay, can you read the question 143?
31-year-old man with moderate hyperopia presents for routine examination.
Sorry, 144. Yes.
In regard to question 143, the examiner
No, we should
elect.
come back to 143. Sorry. Okay, yes.
With moderate hyperopia present for routine examination. There is a 10 prism diopter alternating isotropia at distance. While reading through his distance correction at 20 centimeters, there is a 35 prism diopter isotropia. High movements are full, and he denies any history of prior surgery. You conclude that he must have amblyopia in one eye. He probably has restrictive strabismus. He probably will not double vision if questioned appropriately. He has a high ACA ratio.
Okay, so first of all, he is 31 years old. Okay, number two, he has esotropy. Okay, and esotropy always when you examine it, you bring the prism diopter. Okay, and during the prism diopter, you will examine the esotropia for near and far. How much the prism diopter for esotropia at near, and how much the esotropia at far. Okay, and also you will examine the esotropia with the glasses for near and far, and without the glasses for near and far. And always in each exam, always you should examine the gaze, especially the up gaze, how much at the up gaze the esotropia with the prism diopter, and at the down gaze also with the glasses. This is very important. So we have actually three methods to calculate the ACE ratio, and we can know if it's high or not. That's the simple method. Just there is high ACE ratio or not. Just you bring this is 10 prism diopter of esotropia at distance. So esotropia at distance D is equal 10. Okay, prism diopter.
Mhm.
Then they said when at a distance of 20 centimeters, so at the near there is 35 prism diopter esotropia. So esotropia at near it equal 35 prism diopter. So just here you a clinical method just haphazardly quickly you are not find a time to make the gradient method and the heterophoria method and make all of the calculation. Just quickly you want to see there is high AC ratio or not. Just the esotropia at near 35 minus the esotropia at distance 10, it equal 25. Okay, so here it's this number is 25, this number more than 10. And when the difference between the near and the distance esotropia, okay, here 35 at near and 10 at distance, more than 10, this means there is high ACE ratio. Okay, this is the clinical method. Okay, just quickly, just you measure the esotropia at near, measure it at far, you see the difference between the near and far, 35 at near, the distant 10, so the difference more than 10. More than 10, that means it's high AC ratio. If it's 10 or less than that, that means not high AC ratio. Okay, so this is very quickly. So what's that mean in this case? He has a high AC ratio. Okay, now let us understand how to calculate the AC ratio by other method. Okay, not the clinically method. Okay, by the heterophoria method, the gradient method. Let us understand it. Yes, read the question.
In regard to question 143, the examiner elects to calculate the patient ACA ratio. His interpopular distance is 60 mm, and his near deviation increases to 50 prism diopter when he views an acuity dotted through a 1 diopter sphere over each eye. By the gradient method, his ACA ratio measures
Yes, so here they use a lens. So here the pain point here they give you the interpupillar distance in 60 millimeter, and the interpupillar distance we use it in the heterophoria method, not in the gradient method. Then they told you, and his near deviation increased to 50 prism diopter when he views an acute target through a 1 diopter sphere. So you give him a glasses of 1 diopter. So the gradient method, it talk about the glasses or the lenses that you give him to the patient. Just remember gradient G glasses. You give him a diopter here, glasses or lens or anything, just a way to remember. So here just you put 50 prism diopter minus the minus how much at near. We said he see at 20 centi 35, and you divide it. Okay, now it will equal 15. Then you divide it at 1, the lenses or the diopter that you give it to the patient. So mostly it's 15 over 1. Let me just check it again. Check it from the answer part. 144. Yes, as we said, it's 15 over 1. Okay, now we will read the answer later on. Then the last question, yes, for the patient above using heterophoria method. What is the heterophoria method? Let me just explain it to you. So we have the, the esotropia at near it's 35 prism diopter. You will minus it from the distance. We said at the distance he will see 10. Okay, so it will equal 25 prism diopter. Okay, this is 25 prism diopter. You divide it at the the power that he needed at 20 centimeter diopter. Just let us come back. I know you are confused. He said this 30 prism diopter at 20 centimeter. What is the meaning of 20 centimeter? If we want to calculate the power of it, just you put 1 and you divide it at 0.2, because always it should be in the meter. Okay, this is the power. This is in the optics. We will talk about it. So 1 over 2, it will equal 5 prism diopter. So he needs 5 prism diopter, okay, at 20 centimeter, and he has 35 prism diopter. So this 5 prism diopter, just again for the heterophoria, not the gradient, not with the glasses. 35 minus the distance 10, you divide it at 5, so it will equal 25. You divide it at 5, okay, this will equal 5 prism diopter. Then you will add the pupillary distance plus the pupillary distance. How much the pupillary distance? The pupillary distance always it should be in the centimeter. Here they give you the pupillary distance in 60 millimeter. 60 millimeter, it will equal 6 centimeter. So 5 plus 6, how much it will equal? It will equal 11, 11 ACE ratio. So by the heterophoria method, it will equal 11 over 1. The answer. Now you will read the answer. If you have anything, I will explain it again. Okay? Are you confused or it's a little bit clear? Read it from
A
100.
little bit.
Okay, 143. Read it from here. Yes.
A 25 prism diopter increase is isotropia from distant to near is almost certainly a high ACA ratio. A patient whose distance isotropia increases by more than 10 prism diopter at near is said to have a clinically high accommodative convergence to accommodation ratio.
Yeah, this is the clinical method. Just they bring 35 prism diopter at near at 20 centi minus 10 at far, it equal 25. So 25, it's more than 10, more than 10, more than 10 prism diopter at near. This is high AC ratio. This is the clinical method, the first method. Now the second one, the gradient method, when we use lenses or glasses, read it.
By the gradient method, ACA ratio equals the difference in the deviation induced by a lens divided by the specific accommodative gradient of an extra lens hours distance correction. Minus lenses stimulate accommodation, whereas plus lenses blunt it. Here are 50 minus 35 divided by 1.
Yes.
50 to 1.
So here the gradient method, just in an easy way, you here you give a 1 degree. Okay, this 1 degree it make it 50 prism diopter at near. So the 50 prism diopter with the lens at near minus the 35 of a prism diopter at 20 centimeter, and you divide it at 1. This is the power of the lens that you use it. If you use like a plus 2, you will divide it at 2. So here it will equal 15 over 1. This is the gradient method. You use how much the power of the lens that will lead to the near prism, the near reflex or the near angle. Okay, then you decrease it from the typical near angle at the 20 centimeter or at the distance that they give it to you. Then you divide it at the power of the lens. This is in a simple way. Yes. Then heterophoria method.
By the heterophoria method, they say ratio equals the near deviation minus the distance deviation divided by the accommodative demand at near plus the
Yes. Here,
popular distance.
what is the accommodative demand at near? Just again, we said he any accommodative demand at near, you put 1 and you divide it at the distance that you use it at near. You can see how much he is accommodative at this distance. Like here they said 20 centimeter. 20 centimeter, always it should be you convert it to meter. So 1 over zero point 0.2, it will equal 5 prism diameter. If he said not the 20 meter, if he said the 25 centimeter, so you will divide it 1 over 25, so it will equal 4 prism diopter, not 5. So here, depend on how accommodative demand at the near, you should measure the distance. Then the last thing, you add the pupillary distance. Yes, read it.
Um, plus the popular distance in centimeter. Here is 35 minus 10, 25 divided by 5, reading at 20 centimeter. 5 plus 6.
Yes, so it will equal 11. Do you want me to repeat it or it's clear for you? I can repeat it for the last time if you want.
Mm, it's clear.
It's clear. Okay, perfect. So, position of the gaze. Yes, read the position of the gaze. We will stop here at the laws of ocular motility. Laws of ocular motility, I will make it in another lecture. Yes, read the position of gaze.
6 cardinal positions of gaze are identified in which one muscle in each eye is principally responsible for moving the eye into that position as follows. Dextraversion, right lateral rectus and left middle rectus. Levaversion, left lateral rectus and right middle rectus. Dextra-elevation, right superior rectus and left inferior oblique. Lever elevation, left superior rectus and right inferior oblique. Dextra depression, right inferior rectus and left superior oblique. Lever depression, left inferior rectus and right superior oblique.
Yes.
9 diagnostic position of gaze are those in which deviation are measured. They consist of the 6 cardinal positions, the primary position, elevation, and depression.
Okay, so the position of gaze, it's very important. I will go to the picture. Okay, then we will see it. Here in each position of eye, you should know which muscle it's work. Like here, just in the primary position, okay, here all of the muscles like in its primary position. When we look to the right side, here the left rectus muscles, it will abduct it, and the medial rectus muscle, it will adduct it. This is very clear. And also for the left side, the same thing in the opposite way. Now, the up gaze and down gaze. When we look up, what are the elevator? This is very important. The elevator of the eye. The superior rectus, okay, it will elevate, and the inferior oblique, it will be elevate. So the elevator muscles, they are the superior rectus and the inferior oblique. This is in the center. In the depression, what are the depressors of the eye? There is two muscle depressors, the inferior rectus from down here, it will depress, and the superior oblique from up, it will depressors. So the inferior rectus and superior oblique, they are the depressors. So each gaze, you should know the muscle that work. When we look to the right and up, which muscles it will make this, they make the eye to the right and up in this eye. This is the action of the inferior oblique. As we said, the inferior oblique, it will elevate in adduction. elevate, elevation in adduction. So when you look to the right and up, inferior oblique of the left eye, it will work. And when you look to the left and up, the inferior oblique of the right eye, it will work. Elevation and adduction. Okay?
Mhm.
Okay, this is the inferior oblique. And when we have inferior oblique over action, when you just tell the patient to look to this side, you will see the eye, it will go up. Why it's go up? Because there is inferior oblique over action. So how to examine it? By adduction. Okay. When we tell him to look up and to the right side, this right, what is the responsible for this movement is the superior rectus muscles. And up and to the left in the other eye, this is the superior rectus. So upward in abduction, the responsible for this superior rectus. Upward in abduction. Now let us go to the depression. Depression in adduction, the superior oblique, and depression in adduction, the superior oblique, depression in abduction, the inferior rectus, and depression in abduction in the left eye, the inferior rectus. So here you can know in each position which muscle it works. This is very important. This is the primary here. This is the primary position, and here the cardinal position, and midline the vertical position. These are the diagnostic position gaze, and these are the abbreviation. I hope it's clear. These are the nine cardinal or nine diagnostic cases. They are very important. You should understand each muscle, how which muscle its work when you look up and right. Just I want to ask you, just look up and right. For the right eye, which muscle it work for up and right?
Inferior oblique
And
and
superior
superior
rectus.
rectal.
Okay. Okay. Yes, this is just in a simple way the position of gaze. We finish our small lecture today. Inshallah, tomorrow we will continue in the laws of ocular motility. Best of luck. I hope that I make it clear for all of you. Inshallah, you will get the best benefit from it. Thank you so much. I'm Dr. Abdulrahman Al